The next couple of abstracts deal with the use of fecal calprotectin and interpreting its results in ways that we haven't done in the past. So the first one is using data from the Gemini 1 study. So that's the induction study for using vedolizumab for clinical response as the primary endpoint after week 6 of this drug compared to placebo. During this study, fecal calprotectin was collected both at time 0 and at week 6. So I think we're all familiar with the background regarding this particular large clinical trial. I'm not going to present to you the clinical endpoints. We're all aware that there was efficacious compared to placebo for ulcerative colitis, the primary endpoint being clinical response at week 6. During this study, though, as previously mentioned, about 20 grams of stool was collected at screening and at week 6 to detect their fecal calprotectin, and it was done using a quantitative enzyme-linked immunosorbent assay. So what was different in the way this data was analyzed is they wanted to see if the percent change from baseline could be a way we can help understand or predict whether a patient will respond to vedolizumab. So at the end of week 6, which was the primary endpoint, you could see that those who responded to vedolizumab were much more likely to have a greater change. So their change from baseline was about 80% compared to non-responders. And I should mention that it wasn't just vedolizumab, it was vedolizumab or or placebo, and they were then subgrouped as to responders or non-responders. If you then looked at vedolizumab, not surprisingly, you had a greater change from their baseline in their fecal calprotectin concentration compared to placebo. That was statistically significant. And then looking at that again and separating out those who were a responder on vedolizumab or placebo, both of those subgroups, again, you had a much larger change from your baseline compared to non-responder in either group. And again, the range, particularly if you look at the vedolizumab bar, about an 80% change. So about 20% of their initial level was found in those responders compared to only 50% change in those who do not respond to vedolizumab at week 6. So this is an interesting idea. One of the things we struggle with about fecal calprotectin is what is the cutoff values we should be looking at, and that may not be the best approach for this particular biomarker. It may be more helpful to instead look at a percent change from baseline. And this study, I think, abstract nicely shows that particular result can be helpful in determining those who are a responder versus a non-responder. And you could probably assume this would be relevant for Crohn's or ulcerative colitis and for any medical therapy one uses. Granted, that's not what this abstract is showing. It's only showing the results for vedolizumab in ulcerative colitis. Another abstract which I want to highlight was presented at the UEW, and that was looking at using fecal calprotectin in pregnant ladies. And the reason why that's important is because biomarkers that we traditionally rely on, specifically CRP, we know is not reliable in a marker of inflammation related to IBD in patients who are pregnant, because we know pregnancy can also raise one's CRP. So the background you're familiar with, that they were looking at non-invasive markers to see if one could judge activity of IBD, looking at both fecal calprotectin, but as well looking at CRP. So they picked healthy women planning to become pregnant, so they could have been waiting for in vitro fertilization treatment. They also picked pregnant women who did not have IBD, and then they had pregnant women who had both active and inactive IBD. Now, what's not clear but in the abstract is how do they define someone who had active IBD or not? They collected blood and stool samples, so they were able to measure CRP and fecal calprotectin. And again, fecal calprotectin concentration was quantified using an enzyme-linked immunosorbent assay. So in total, 103 patients were enrolled in the study. 19 women were planning pregnancy. 21 were healthy pregnant females. 40 patients had active IBD. 23 patients had inactive IBD. So a pretty reasonable spread amongst the various scenarios they wanted to look at. They saw that fecal calprotectin concentration was significantly higher in both active and inactive IBD patients compared to pregnant women. and also those who were not pregnant and did not have IBD. They didn't see that same separation using CRP, that there was no significant difference in detecting CRP levels between the groups, and there was no difference could be detected in the fecal calprotectin concentrations between pregnant and non-pregnant healthy women. So pregnancy doesn't necessarily drive up your it doesn't necessarily drive up your fecal calprotectin shown in this study. So this is helpful because we know that we want to, as best as we can, manage the inflammatory burden in pregnant females, because we know the impact that that could have on both obviously the patient but also in fetal development. And we also know that invasive procedures or invasive tests like a CT scan with radiation or a colonoscopy has their own risks in pregnancy. We also know that CRP is not helpful because it rises in pregnancy. So having a non-invasive, reliable biomarker like fecal calprotectin to be used in pregnancy may be a very important use of this particular new test that we now use in Canada. So the final abstract, which I'd like to walk you through, was presented at the UEW. The title of it being Withdrawal of Azathioprine in Patients with Crohn's Disease in Stable Clinical Remission, a double-blind, placebo-controlled 2-year trial. So this is a randomized controlled trial, a withdrawal trial of azathioprine, and the follow-up was for 2 years. These patients who were eligible had to have had a continuously been on azathioprine for a minimum of 4 years without an exacerbation of their disease in the previous 12 months before enrollment, and they all had to have been in clinical remission defined as a CDAI of greater than 150. They were then randomized, 26 patients continued on azathioprine, compared to 26 patients who were switched to placebo. The primary endpoint was time to clinical relapse during follow-up. The results, so during the 2-year follow-up, there were clinical relapses detected in 4 patients on azathioprine compared to 8 patients in placebo. Looking at the proportion of patients in clinical remission at 12 and 24 months, you see that was higher in the azathioprine group that continued, so it was 96% remained in clinical remission, compared to 76% who were in placebo. And then at the end of 24 months, it was 86% compared to 69%. Where it was statistically significant was at that 1-year mark, seeing a difference in those who continue on azathioprine versus those who were switched to placebo. So what does this mean? This is not a new study in that it's a new study, but the results are not new, and that we had the previous Jataid withdrawal study which showed a similar finding, that continued use of azathioprine even after 3.5 years in that study was better than going on to placebo. I bring this up to kind of bring again into the forefront this issue of azathioprine and where should we be using it as monotherapy. And that relates obviously to the recent Health Canada warning about azathioprine, and the use of this medication as monotherapy has potentially questionable benefits with known risks. So I think that how we approach that particular issue when starting a new patient on therapy, when we have so many options, I think that's quite clear. But this highlights, this abstract, the fact that in a patient that's done well, that potentially the benefit-risk ratio is very different than in someone who has yet to be on this therapy and we don't know what their benefits are. So if you're selecting out, and the reason why that's important is the issue of what to do when patients are doing well on azathioprine alone. And it reinforces the fact that we have to discuss both the benefits and risks about that approach, about using azathioprine in monotherapy. And in some patients, it really does make sense potentially to continue their therapy. And we know that that risk of stopping their therapy, as was shown in this study, even after 4 years of being on the drug, is that the patient is at a higher risk of having a clinical relapse. Thank you for your attention. I hope you enjoyed this presentation and you learned something new about what's happening and upcoming in Crohn's disease. I certainly hope to see you again after the DDW in 2015. And now on to the next presentation.